people that weren't able to join us today. We are so excited to have 23 practices participating in the project. This is the list of practices here. Excuse me. Our project goals are pretty straightforward. The improving the rates of depression screening throughout the project, improving the capture of the depression screening using LOINC codes or G codes, and improving the rate of captured follow-up, strategizing about best practices, excuse me, and standardizing workflows. The initiative aim statement is as follows: participating PHN practices will increase the rate and capture of depression screening in patients 12 years of age and older, 10% from baseline by the end of the project, which is the end of the data capture will be October 31st, and sustain that improvement for 6 months, or we presume improvement, right? This below is the aim statement template. When your practice gets together in the next couple of months to decide your strategy for the project, you will use this template. An example would be, friendly pediatrics will increase the capture of performed depression screenings in patients 12 to 17, 5% from baseline, and sustain for 6 months. So you will tailor this to what it is your practice wants to follow and wants to improve on. We restricted our aim statement to screening and not follow-up because we know that increased capture of depression screenings is going to affect the follow-up rate. Our follow-up rate is currently very high, but we're not sure what the impact of additional capture will be on this follow-up rate. So while we will continue to monitor it and look at it in our scorecards, we did not include it in our aim statement. So Jessica is going to review the depression screening and follow-up measure. And in case anybody hasn't met Jessica, this is Jessica Chapman. She is a couple months in to her stint as a QI consultant coach for the QI team at PHN. Jessica?
Okay, so just to kind of get into some basics here, and if anybody has questions, feel free to stop me or post in the chat. But this is the depression screening and follow-up for adolescents and adults measure. So like Charlotte said, we're kind of focusing specifically kind of on screening, but there's opportunities for improvement with both. So technically this measure has two components. So per HEDIS, this is the measure of members 12 years of age and older who were screened for clinical depression using a standardized instrument, and if screened positive, receive follow-up care. And this is within the calendar year, so January to December. And then there's coding, which we understand is a challenge, which will be a huge component kind of the QI initiative. Per HEDIS and NCQA, the national standard is LOINC codes. We know that G codes are also kind of a big component of this, accepted by some payers. We also recognize that some EMR systems make it very challenging to add G codes. So we are aware of all of this and want to work with you. But our kind of PHN recommendation is to try our best to utilize LOINC codes, but do what works best with your practice and what you guys decide works for you. And then this 96127, that is the behavioral health assessment code. Okay, and then the follow-up portion of this measure. And a caveat to this as well is these are just the different opportunities to meet the measure. If your practice really wants to take a deeper dive and work on really enhancing your follow-up for your kids, that's available and will support you through that. These are just the components to meet the measure that we'll go through. So if a child scores positive, any of the following on or up to 30 days after the first positive screen can help to meet the follow-up component of the measure. So the first one is an outpatient or telephone follow-up visit with a diagnosis of depression or other behavioral health condition. Second opportunity is a depression case management encounter that documents assessment for symptoms of depression or a diagnosis of depression or behavioral health condition. There's a behavioral health encounter, including assessment, therapy, collaborative care, or medication management. Fourth would be a dispensed antidepressant medication. And then the fifth would be a receipt of an assessment on the same day and subsequent to the positive screen. Specifically with number 5, that would be that if your practice administered like a PHQ-2, the child scored positive. So then you went ahead and administered the PHQ-9, and the PHQ-9 didn't show evidence of depression. That's what that component is specifically talking about here. And then any questions specifically on this?
Tiffany here, Dr. Moore with Nova Pediatrics. Just a quick question. Are you guys going to discuss what about our folks who are coming in with diagnoses of depression or a diagnosis of depression who are already being managed by psych or us or whoever?
Yeah, there's an exclusion criteria, and feel free to jump in, anyone on the QI team. So I believe within the previous measurement year, if the child has a diagnosis of bipolar or depression, that's exclusion criteria. But Charlotte or Eric, I don't know if you have other to add.
Yeah, hi everyone. It's Erica, the other quality consultant on the PHN quality team. As Jessica said, if the patient has an established diagnosis of depression starting the year before the measure, so that would be in 2022, they'll be excluded from the measure. And in terms of documentation options for patients who are getting treatment elsewhere with a psychiatrist or with a therapist, and putting that documentation or coding in an encounter or a telephone encounter is something we're looking into, because we know a good amount of patients who screen positive will be in that situation. So it's something we are exploring and know will be very important for the follow-up component. So more to come on that and those documentation options.
Yeah, so if let's just say a psychiatrist filed a claim to the same insurance company to say that they had depression in the previous year, that would be excluded as well. The tricky thing, as you guys know, as clinicians, is behavioral health. It's difficult because some people pay out of pocket, some people have different insurance coverage, so it just gets trickier to capture the data. What I think is interesting, I've worked a lot on this measure, and I can tell you this follow-up piece, I want you guys to fully understand, because if you read that first sentence, any of the following on or up to 30 days after the first positive screen, if your patient has a positive PHQ-9 at their 12-year-old well visit, and you diagnose the patient with depression, and it's linked to a LOINC and or a G code, you have already followed up with the patient. Does that make sense? That is actually incredibly generous from the contracting side to give credit to providers, but that's what Jessica was mentioning when she was saying that if you actually do just want to work on, that that's not following up, right? That that's acknowledging the positive screen in front of you. But if you really do want to work on connecting that person within 30 days, we want to encourage you to work on that workflow as well. The difficult part will be capturing that through Arcadia, because Arcadia goes off the HEDIS metrics. I don't want to confuse anyone, but it's tough. Go ahead.
Dr. Schwartz?
At some point, can we get a list of ICD-10s that the HEDIS will consider depression and anxiety? Like, there's mild depression, this and that, and there's adjustment disorder, and I don't know. It would be helpful to know what. Good. And then the second thing is for our office right now, if there's a positive depression screen, we're doing a suicide risk assessment after, but I want to make sure that we're using codes that that are compatible with HEDIS measures. So at some point we'll get some information about that too. Thank you.
Yes, thank you, Dr. Schwartz. Dr. Watts?
Yeah, I think that it kind of goes along with diagnoses. I think you could easily meet the measure at 100% by diagnosing them with depression, but the PHQ is really not diagnostic of depression, and I think we need to be really careful to do good medicine first and not be diagnosing all of these people with depression in that same day.
a very
We
good
totally
point.
agree, Dr. Watts. And I mean, for reference, our follow-up rate is already very high. And as Dr. Bogard mentioned, that's fantastic for the contract, for, you know, this HEDIS measure. Is it indicative of perfect care? Probably not. But we want to support you in first of all meeting the measure, maybe, but also providing the best care for patients. Obviously, there will be a lot more discussion on this going forward, so we will just continue on this presentation, but thank you so much for your comments. Oh, will we continue? I don't know. There we go.
Okay,
Claire?
well, as we just mentioned, the follow-up rate's very high. And again, you can think of many, I'm already thinking of many interventions we could put in place to make that work. The depression screening rate, I'm sorry, is about 39% for the participating practices in this initiative. The range is pretty wide. It's from 0% to 63% capturing that screen within our Arcadia. What we will do is let you guys know where your practice lies if you have any questions about this. We've also gathered information on what codes we're actually able to capture in Arcadia. Keep in mind, Arcadia is still gathering the EMR data and the claims data. And we fully recognize that this project, since we're going to be using Arcadia much more than chart reviews, which hopefully is a nice break for you guys. I see nodding already. We also fully anticipate that there's going to be times where you're like, wait, this number doesn't make sense. Clinically, we see that we're doing this. Arcadia is capturing this. So if you can think about that as like a process measure or like a side quality improvement work that's going to help just really validate and solidify the data that we have in Arcadia, just keep that in mind. We are happy to work. We're going to be coaching you guys and working with you one-on-one to make sure that what you're clinically doing is being represented appropriately in the data. And then
I'm sorry. Go ahead. Go ahead.
No. I was going to go on to the next piece. Go ahead, Charlotte.
Okay, I was just gonna clarify some things in the chat. So when Claire gave the example of the 12-year-old for their well visit coming in, gets a positive PHQ-9, you use either the Woink code and the score, or you use the G code to indicate a positive depression screening. That does not meet the measure for follow-up. The follow-up is then, you know, you have that positive PHQ-9, you have a discussion with the patient, and then you diagnose that patient with depression. That's what meets follow-up. There's like a little bit of a tricky bit where you have to have a follow-up code, which is a CPT code, and attached the Z code for depression. And Dr. Schwartz, I do believe that like the mild depression meets the measure for follow-up, but we'll look into the very specifics. But no, the G code does not meet the measure for follow-up. The G code is just for screening. And then just one more question in the chat, Dr. Bach. Am I hearing this only applies to the first positive PHQ-9 in the measurement year or for all time? I think we'll have to get back to you on that.
Okay.
That's where, like, if your workflow is to universally screen, including your known depressed patients with a PHQ-9 and it returns positive, that's where that exclusion criteria will help you. Because if they've ever been diagnosed with depression, it doesn't matter if you screen them or not going forward. And so they'll be excluded from this measurement.
So then should we not use the G codes for those patients that already have had a positive PHQ-9? And just like trying to kind of follow, because I don't want to stop doing the PHQ-9 because I think it's valuable to ask those questions yearly, especially in a depressed patient. But I don't know.
I think, you know, following up with your depressed patients is good practice. I also know G codes can be a huge hassle in some EMRs. So it's a balance of provider well-being and giving the patient what they need. But what I can tell you from a measure perspective, if they were labeled with depression in the last year, we're not looking at how you're screening them and it for the HEDIS metric and for the value-based care contracts. So it's really up to you, I would say. That's the cool part about network initiatives is we get to kind of share what we know and how it's defined, but you guys get to really tee it up to the way your practitioners and your practice likes to operate. But we're happy to bounce ideas off of.
Thank you.
Of course.
Hi, this is Jenny Yu. I had a quick question. So for some of my patients who are, I guess, resulted as positive, but then when I go over the questions with them, they are like, oh, this is only because of my sibling or whatever. So, and they don't really feel like they're depressed, and I don't feel like they're depressed. So how do you, I guess, account for that in the positive screens?
That's a really tough question. I think that we all deal with that clinically, right? Like I know in my EMR, we use a smart form that quickly labels someone with, mild depression if they're just, having trouble sleeping mixed with like one or two other symptoms, which is not always depression. And so what I would say to that is if they're answering the question wrong and you can go back and change the way they've answered the response to be more accurate, then please do, because that's more accurate to the response. But like I had a patient who ended up having mono that looked like they were depressed on paper, but really it was related to this infectious disease. That's a person that I'm not going to follow up with on depression. Though in the contracts, the threshold to meet the standard is purposely lowered to consider groups like this. Does that make sense? So remember, the contracts don't require you to do this 100% of time, even though we want to be able to follow up and we want to be able to screen people 100% of the time. They know there's these nuances and that's baked into the contracts. And I'm happy to review those numbers with you guys individually if you'd like.
Yeah, I mean, the follow-up is just so tricky. And I think for every patient, it's different, but like Claire said, our goal is not 100%. So we do try to account for those nuances. Okay. Okay, for the current state of, sorry, go ahead.
No, go ahead.
Okay, for the current state of affairs for screenings, that we have found this data through Arcadia. For 22 practices, this is representative of 22 practices, 35% of the practices are using LOINC codes and a G code for these screenings. 13% are using LOINC codes and 52% are using G codes only. 52% of the practices on this call are using online or electronic and paper screenings, so the combination. 9% are only doing electronic and 39% are only doing paper screenings. Of those electronic screenings, 36% are using Chattis. Okay, that was really weird. Okay.
We can hear you now.
And 28% are using Phreesia. I lost my train of thought here. I will say this is great information to have. It is not necessarily, one is better than the other. Everybody's doing what works for their practice, and we'll go into kind of best practices later on in the presentation. Like I said, everybody's doing something different. This is the list of practices and what we have found. This is all according to the annual practice survey. Thank you all so much for submitting it. You can see that a lot of practices are screening at both well child visits and behavior or mood specific visits. Almost everyone is screening, at age 12 or before. And these are like I just said, the modes of the methodology for screening, electronic only, paper and electronic, or paper only. And these are the codes that I have found in Arcadia. This is not necessarily universal or exhaustive to your practice, but this is what I have found thus far in Arcadia. And we will, of course, be diving deeper into this as the project moves forward. Like I said, best practices. From the current information that we have, the best practices that we have found is, first of all, just screening, using a validated tool. There's an opportunity to screen at more visits. We encourage people to start screening at age 12, and we do encourage LOINC codes for tracking the screening. The reason being, it's connected to automation. So anything that we can automate to decrease provider burnout or, human error is fantastic. Each practice will have its own. Each practice is different. Each practice's approach will be different. And we are going to convene groups that have similar practices or similar workflows so that you can convene and optimize your EMR or your software to make sure that the screenings are being captured. Like I said, there is, while these are best practices, there's not a clear correlation between these practices and a high rate of depression screening. So you have to do what's right for your practice. If it ain't broke, don't fix it. Just, reupholster it or refurbish it. We're not trying to break everything down and start from zero. Everyone in this initiative is screening, so no one is starting from zero. So this particular project is going to run in 3 phases, and we're really excited about this kind of setup. In the first couple of months, this is when your QI team leader and participating providers and everybody on the practice team that's participating in the project will really brainstorm your approach to this project. You will identify an aim statement. It can be focused on depression screening. It can be focused on follow-up. It can be captured purely on coding. It really is up to you. And what will drive that decision-making is the data. Obviously, that's what drives most of our decisions here at the QI team. It will be the data as well as your practice's work on like QI worksheets. So we will be coaching on how to use a fishbone or a key driver diagram or a process map to identify the barriers to success in this initiative, or in this measure. And that's when you guys will identify what you would like to work on. Was there a question? Did I see a hand go up? Okay.
There are a few, Charlotte, in the chat that maybe we can close out at the end with.
Okay.
And go from there. Okay.
Thanks. From that fishbone diagram, from those QI worksheets, you will be able to identify the barriers to success and strategize on an intervention. And so in the summer months, we are asking you all to conduct at least 2 PDSA cycles. Of course, quality improvement is an ongoing process. So if you want to do like 9, 10, 11, 12 PDSA cycles, that's cool. But this is when you'll implement the PDSA cycle to improve on the rate. In September and October, we hope that you will have found an intervention that works for the participating providers, and you will be able to scale it up to practice-wide, location-wide, just adding more providers as you go, however you're able to scale up. Any questions on that before I move on? We're really focusing on quality improvement throughout the 6-8 month project, really focusing on getting that down. I don't know. Your QI team leader is a very important person on this project. There are 4 QI team leader meetings where you'll meet with the PHN QI team. These are the dates and times, and these are the topics. We are going to look into aim statements, fishbones, and jump into the Arcadia platform for you all to really access this data and see it as we see it. The next meeting, we're going to be working with you to identify interventions, looking at the fishbones that you created, and going into each practice's fishbone and seeing what PHN may have missed so that we can assist you going forward. In September, y'all will report on your PDSA cycles. We'll talk about what worked, what didn't work, identify best practices. And then, of course, we will have the project close, a little post-mortem on the project. And then in April 2024, PHN is going to reach out and check in and see how sustainable the intervention has been. Claire?
Yeah, so part of QI initiatives for MOC credit require educational webinars. And we really want to make sure this is tailored to what you guys need. So we're going to start off in April, and these dates are still slightly fluid. We're confirming with the speaker now. But essentially, we're going to have a presentation on like the national trends on depression screening and follow-up, and really best practices to make a 30-day follow-up even possible. And then when we have our educational seminars this summer and this fall, we really want to hear from you guys what you want to hear about. And we think we're going to learn about that through our team leader calls and our coaching calls with you guys. So if you guys are PDSA, if you're cycling through these PDSAs and you realize that you need more information or more training for staff or more, I mean, already in the chat, right? Like the billing and coding session could be one in and of itself. These are all things we want to hear from you. And then we'll put together an educational webinar to really work you guys, give you guys the information you need and get the right speakers. So more to come on that. But the hope is that it's really tailored to what you want to hear as opposed to us predicting what we think you guys will want to know. So we'll keep abreast of that and let you know, but send any suggestions our way. And then, is that Dr. Fugate? Raise your hand. Candace, did someone raise their hand? All right, let me know if not.
Okay, thank you. Oh, boy. So this project is eligible for 25 points for MOC Part 4 credit. These are pretty standard requirements. I will track them all for you, but the educational webinars will be required. Your your QI team leader will attend the QI team leader meetings. And then these last 3 rows are really making sure that people that are seeking MOC credit participate in the PDSA cycles and the analysis of the data. So Arcadia, we are excited for Arcadia, and this is going to be a tool that we are using throughout this project. And if you do not have access, I think there's 5 or 6 practices in this initiative that do not currently have access. So we will be reaching out to you, but please, if you want to take, if you want to take the time to send us an email to phn.arcadia, we will get you access soon. PHN Talks is, I hope you've heard about it through the newsletter or other PHN communications. It's a Teams platform. Right now, this call is being conducted on Teams. It's a Microsoft tool. We will be creating a specific page or a specific channel for this QI initiative, and that is what is going to replace Glass Cubes. I don't know if anybody's sad about that, but Glass Cubes is gone. So I don't know if there's anything, I don't know, Rachel, if you want to shout out PHN Talks, but it's a great tool for for other things. Thank you, Dr. Bach. Thank you, Sarah. Yeah, it's a great tool for other things as well. You know, educational resources. The practice managers have their own channel. That's an exclusive club though. So, but join here, click that link and you can sign up, and then I will add you to the specific team channel. I also wanted to add these online resources for depression. Children's National Psychiatrists have gotten together with the PHN to identify great resources for a variety of subjects on behavioral and mental health. This link specifically goes to the depression resources, but please explore that all of those resources if you can. Any questions about Arcadia or PHN Talks?
Can I jump in really quick about Arcadia? I see a couple questions in the chat that'll
Thanks.
just be easier to answer instead of typing. So I see a few saying they're using LOINC codes. We're not seeing that in Arcadia. We can look at that, and we can look at the way that you're documenting them and see how those are being mapped or coming through to Arcadia. So we'll follow up with you, Dr. Schwartz. I know we actually are meeting this week to set up your access, so we can take a look at that with the IT team and see how you're documenting that and see what's coming through to Arcadia. So we can definitely take a look at that. And then in terms of LOINC codes and Arcadia and getting those to the payers, we do see them in Arcadia, but Care First is using FigMD to capture EMR data. So that is how that's how Care First is going to get the LOINC codes, and you'll use the LOINC code for the screening and then either a numeric result to see if the screening is positive or negative, or use a G code for a positive or negative result. That was just wanted to answer those questions in the chat. Thought it would be easier talking versus typing to answer those.
Yeah, okay, Angela, thank you. I see your message. All right. Okay, so next steps. Getting Arcadia access, signing up for PHN Talks. And then the next step for your practice team is your QI team leader will review the data. That is probably going to be at the first QI team leader meeting, which I believe is April 17th. I will share the link to PHN Talks right now in this chat. But so basically next step is to start brainstorming, looking at your data, writing an aim statement, looking at a fishbone, etc. So really strategizing about your approach. So that's the conclusion of my slides. I feel like there's a lot to be talked about though. What's in the chat, Claire?
It was mostly what Erica addressed. It just
okay.
by then we moved on to the next piece, so I didn't want to interrupt it. Yep, thank you, Erica. Erica's doing a good job of kind of acknowledging the nuances. I think the chat is just symbolizing what we knew, which was just there's a lot of individualization to this, and that figuring out how to translate what you're actually doing in practice to capture data is going to be a big piece of this work. With that said, it's worth it because at the end of this, hopefully we have a really good link between all of your data and Arcadia, and we understand what's going in and what you're clinically doing. And then, yeah, we'll meet again in just a couple weeks to talk through some QI methodology and really help you guys understand your processes around depression screening and follow-up, and the areas that are most low-hanging fruit to kind of capitalize on or improve, or the ones that can really be automated to help sustain the work that you're doing so you don't have to refocus this every couple years to keep your targets high.
Can I clarify something? So the next meeting is 4/17 with all of us, with the QI team, or do we have, as a team leader, do we have to meet with you before that meeting?
That's a good question, Dr. Roth. So this April 17th is just the QI team leaders. So whoever's head of your practice, I mean,
Right.
you, but But before that, we will be sharing probably via email,
Okay.
kind of a summary of what we are seeing in Arcadia. As Claire mentioned, the rates that we're seeing in Arcadia vary widely amongst these practices from 0% to 62 or 63%. And what we have discovered in looking at the data and the answers to the annual practice survey is that each practice has a different strategy. Not every practice, you know, there's Chattis, there's Phreesia, there's EMR tools, there's paper only. So we're trying to figure out how to coach each practice, and Erica and Jessica are going to be working overtime to coach each practice with their particular workflow. So before that April 17th meeting, you will have access to your data in Arcadia. You will have a look at your current rate, and you'll see and we'll report to you what we see in Arcadia. So like, do we see LOINC codes coming through for every depression screening at your practice, or only G codes, or what? So it's going to be a lot of digging into the data before that meeting. Did that answer your question? Okay.
Any other questions?
I have a logistical question. With the team leader meetings versus the meetings we're to have with our practice team, does it make sense to have them after the team leader or before the team leader meeting? That part just logistically would help me out a lot.
Sure. Yeah. You know, honestly, we were trying not to be too prescriptive about like deadlines and stuff for this project. In my mind, and everybody correct me if I'm wrong, it makes sense to me to have those meetings after the QI team leader meeting. So you'll have the data after that meeting. You'll have and then that still gives you about 4 or 6 weeks to strategize about your approach to the project.
Okay, thank you.
What I like about this project is it gives you time to really explore the processes and the data and where the barriers are, so that you can really move the needle on what will change your outcomes, which is great.
I have a question
Go ahead.
for those in our practice who aren't on the call, and they're going to want to watch this recording. Will they need to sign up for Teams before they can watch the recording, or will they, like, do I need to send them instructions of how to sign up for Teams before they watch? Or will there be somewhere else they can get the recording?
That's a great question. No, I'll email it to everybody that is in the project, so that everybody can see it, and they'll have the slides as well. Yeah, great question. I'll email it out. Well, it feels like we're on the road to improvement. If anybody has any other questions, I can see that there was a lot of discussion in the chat. We'll try to capture all of that as well. But yeah, we're excited, and we're excited to start sharing the data with you, getting you into Arcadia so you can see the data that we're seeing.
Can I jump in with a really quick question? Hi. We had previously posed some questions to you guys, and in the chat I saw that it said that some of the measures are still being determined for this year. I don't know if there's a question in here, but it seems like for all the type A plus people out in the world like me, like it would be really rad to have the measures and the answers first so we can set our goals. Is that feedback you can bring back to the payer? I just need to say that out loud so I can move on with my life.
I love it.
There is a question in there somewhere, but thank you.
I think what we also would love to have the measures are almost, I mean, nothing's been signed yet, but the measures are mostly determined. It's the targets that are varying. And from what I can tell you from behind the scenes, they're not going to be far off what they were last year. They're going to be very similar targets. So with that's with the contracting side of my brain. With the QI side of my brain, it's really hard to move something more than 10% in 6 months. So take your baseline, and 10% is a pretty basic goal. And actually if you achieve it, it's really successful. So I'm with you, and I love trying to get the A++ rating. And if we all could do that, that'd be great. It's messier than that, unfortunately, but as soon as we know it, we'll give it to you. And again, this would be next year would be the first year we might actually have all the data in Arcadia as soon as the calendar year, which is the contract year, switches. So the hope is that these decisions aren't claims based, though I can't promise that because that's how the insurance company validates what we see already. But we hope with time, and as these relationships and contracts keep going, that we're able to move this deadline of like Q2 kind of finalizing things up closer to the beginning of the calendar year, because that is frustrating from a quality team when we get data they're 6 months older. Like, and again, over the last year, 3 months made a huge difference on everything from utilization to staffing to everything else. So we recognize that it's really hard to do quality work with data that is delayed, even if it's just a few weeks. So great question.
My 2 cents on that is that the insurance companies always act like, why do you all need this so quickly? Why are you in a rush? Like, it's very interesting. Like, for those of us who have the perspective that it helps move this QI work forward, they're always like, we'll get it to you. And I think for them, it ends up being like a second quarter thing, which doesn't necessarily help us, but that's the space we live in.
I will also add that for this particular measure, the payers are, the payer that tracks this measure is pleased with our performance. I'm not going to go like effusively into it, but they are pleased with our performance. Very pleased. So I don't think they'll be moving the needle too much.
Yeah, we're a high performing network. So I would just say I'd keep it local and ideas and goal setting. And if everyone does that, the whole network will achieve it. So.
All right, thank you guys so much. We will be in touch with this recording, the slides, and hopefully this week or the next, your baseline performance as we see it in Arcadia. All right.
Good afternoon,
Thanks,
everybody.
guys. Appreciate it.
Thank you.